referred to as melancholia. Okay, and this is a common mental health disorder that is characterized by persistent feeling of sadness, loss of interest in activities and pleasure, and also other symptoms that normally affect how an individual feels, thinks, and handles daily activities. So, globally, there is an estimated 5% of adults who suffer from depression, and this translates to around 380 million persons. This condition affects more women than men in a ratio of 2 to 1. South American region is the one that is mostly affected, along with countries like Greece, Spain, Portugal, Palestine, and Tunisia. In Kenya, we have 1 in every 4 Kenyans that may be suffering from this condition, and it could be of different type. Some could be major depressive disorders, which is normally characterized by persistent feeling of sadness or loss of interest in most activities. Global statistics show that around 17.3 million people are affected by this disorder. Or it could be the persistent depressive disorder, abbreviated as PDD, and this was previously referred to as dysthymia. And this one involves long-term symptoms that may not be severe but will last for years. Or it could be bipolar disorder that involves depression as well as moments of elevated mood, which we normally refer to as mania or the hypomania. Or the seasonal affective disorder, abbreviated as SAD, and this is depression that occurs at certain time of the year, and globally it usually happens in the winter months where there is less natural sunlight. Lastly, it could be postpartum depression, and this type of depression occurs after childbirth, and it can range from mild to severe forms. So depressions affect us in different ways. Number one is that it raises and increases the risk of committing suicide, as you find that depressed persons may find these committing suicide to be a way in which they can be able to escape this emotional pain. For that case, depression for your case has been ranked as the leading cause of suicide worldwide. Also, depressed patients could also be unable to take care of themselves properly because of the self-neglect. Depression has also been associated with diseases such as cardiovascular diseases, diabetes, chronic pain, and even weakened immune system. People who are depressed are likely to turn to alcohol or drugs as a way to cope up with their symptoms, and also depressions could also affect our cognitive ability. In that you may find they may increase the risk of accidents for the drivers who are driving or people who are operating machines in factories. Lastly, depressions also have an effect on our suicidal behavior. In most cases, it increases our suicidal ideation, right? So as to be able to avoid such emotional pains for that case. Okay, so how do we treat these depressions? Well, in pharmacology, we use antidepressants. Okay, for your information, we already know that depression is thought to be as a result of functionally deficient monoaminergic transmission in the CNS. That is reduced noradrenaline or the serotonin in the CNS. Okay, also, recent evidence also suggests that depression may be associated with neurodegeneration or reduced neural formation, okay, neurotransmitter formation in the hippocampus. So, pharmacological manipulation just to enhance monoaminergic transmission now remains the most successful therapeutic approach in managing depression. So, we have different types of antidepressant drugs. We could have the TCS, which are tricyclic antidepressants like amitriptyline, imipramine, and the cypramine, or selective serotonin reuptake inhibitors like the fluoxetine, paroxetine, and sertraline. Now, next we have the selective noradrenaline reuptake inhibitors, followed by monoamine oxidase inhibitors, the MAOs. And then lastly, we could have the atypical antidepressants. These are drugs that can neither be grouped as tricyclic, selective serotonin reuptake inhibitors, nor the selective noradrenaline inhibitors, or even the monoamine oxidase inhibitors. So we have like the mirtazapine, bupropion, the agomelatine, and the trazodone. Okay. But generally, we have some rules that normally come up with these drugs. Okay, so these drugs, they normally elevate the mood of a person, so they might increase the risk of committing suicide, especially in the first weeks of treatment for that case. And this kind of trait is more associated with the selective serotonin reuptake inhibitors. The age group that is commonly affected is between 18 to 24, so you have to advise the patient to notify the healthcare provider if there's any suicidal thoughts. Also, the healthcare provider has to clarify any prescription, and the RN has to ensure that they are monitoring any new thoughts of suicide, any unusual behavior, worsening depression, or any sudden changes in mood. All right. Number two is that they also have a slow onset. For example, most of these antidepressants could take at least between 2 to 4 weeks so that we can be able to see their effects, right? And also, we also need to slow temper off them, okay? We don't need to stop them abruptly. If we do, we could have severe consequences. Number three, you have to ensure that you don't mix the antidepressants, you don't co-administer. If you do, there is a highly increased risk of a patient developing orthostatic hypotension. So you have to avoid combinations like also taking SSR, that is serotonin selective reuptake inhibitors, with herbs like the St. John's wort, okay, or the combinations between monoamine oxidase inhibitors and other antidepressants. It could be the TCAs, SSR, or SNRIs, right? Lastly, when used with antipsychotics, they normally decrease the blood pressure, okay? Mostly the resulting in orthostatic hypotension. So you have to advise the patient to slowly change the position, all right? Also, other associated factors, side effects with co-administration with the neuroleptics is also weight gain, right? So we can start with the first one, which is the old class, that is the TCS, the tricyclic antidepressant drugs. The main immediate effect of the TCA is just to block the uptake of amines by the nerve endings and by competing for the binding site or for the amine transporter. Some TCAs also normally increase transmitter release indirectly by blocking the presynaptic alpha 2 adrenergic receptors. So it has been suggested that improvement of emotional symptoms reflect mainly an enhancement of serotonin-mediated transmission, whereas relief of biological symptoms result from facilitation of noradrenergic transmission. So most tricyclic antidepressants affect one or more types of neurotransmitter receptors, including the muscarinic acetylcholine receptors, histaminergic receptors, and serotonergic receptors for that case. So when you block the muscarinic receptors, it results into anti-muscarinic effects, and these effects could be side effects like having a dry mouth. Of course, we know these agents normally dry the patient. So the patient will have dry mouth, blurred vision, constipation, and even urine retention for that case. What about the other receptors for this is for the antimuscarinic, okay? What about the histaminergic, right? Histaminergic and adrenergic. So for the adrenergic, will result into postural hypotension, particularly in very old patients. Also sedation, drowsiness, and difficulty in concentrating. Remember, overdose could result into prolongation of the QT interval, predisposing this patient to ventricular dysrhythmias. So even usual therapeutic dosage of TCA can also increase the risk of sudden cardiac death significantly. Fits also may occur when you withdraw these tricyclic antidepressants for that case. Examples of these drugs include the apramine, the clopramine, amitriptyline, nortriptyline, doxepin, and desipramine. Okay, remember amitriptyline is known for the sedative effects and it's often used to treat insomnia associated with this depression. Generally, these drugs have to be avoided in elderly patients because of its anticholinergic effects and majorly because of the orthostatic hypotension. We could have acute toxicity. Remember, tricyclic antidepressants are dangerous in overdose. So the main effects are on the central nervous system and the heart. The initial effect of the TCA overdose is to cause excitement and delirium, which may be accompanied by convulsion. So this is followed by coma and respiratory depression lasting for some days. Atropine-like effects are pronounced, including flushing, dry mouth, skin, mydriasis, inhibition of the GIT and the blood. And anticholinergic drugs can also be used to counter these atropine-like effects, but they are no longer recommended. Cardiac dysrhythmias are common and sudden death is very rare, but it may occur from ventricular fibrillation that we had mentioned. In terms of drug interactions, TCS are hepatic microsomal metabolism. All right. So TCS, you find that this system is very important for the elimination of this TCS. Okay, so this may be inhibited by competing drugs like antipsychotics and some steroids. So tricyclic antidepressant can also potentiate the effect of alcohol and anesthetic agent, resulting in death secondary to respiratory depression. TCS can also interfere with the action of various antihypertensive drugs, which can potentially lead to dangerous consequences. So their use in hypertensive patients requires close monitoring because there is a likelihood of developing severe hypotension. TCS are rapidly absorbed when they are given orally and they do bind strongly to plasma albumin, most being around 90 to 95% bound at therapeutic plasma concentration. So they also bind to extravascular tissues. So extravascular sequestration together with this strong binding to plasma albumin means that hemodialysis is not effective as a means of increasing drug elimination in case there is an overdose or toxicity. So TCS are metabolized in the liver and both the desmethyl and hydrolylated metabolites commonly retain biological activity. For the complete inactivation of these drugs, it occurs by glucuronide conjugation of these hydroxylated metabolites. So these gluconeurides being excreted, you find them excreted in the urine. Hepatic metabolism of the TCA is determined by both genetic and environmental factors, and there are wide inter-individual plasma level variation. So if you want to work with these drugs, you have to ensure that you are titrating these drugs individually with therapeutic responses or adverse effects as the endpoints. The overall half-lives of elimination of TCS are generally long, ranging from 10 to 20 hours for like imipramine and the simipramine to about 80 hours for drugs like the protriptyline, and this half-life may even be longer in elderly patients. Therefore, gradual accumulation is possible and this could lead to slowly developing side effects for that case. What is the clinical uses and dosages for this TCS? You find that the tricyclic antidepressants like amitriptyline, imipramine, they are used for moderate to severe depression, especially with the psychomotor features such as insomnia for that case. All right, so you could find that you could have a sedating drug such as amitriptyline will be used for that case. Okay, so because of the unwanted effects, it is prudent to start with relatively low dose and then titrate it upwards to a therapeutic dose over 1 to 2 weeks. So you could have like 25 to 75 milligrams orally titrated now to at least the maximum between 100 to 200 milligrams daily. So beside the TC use in depressions, tricyclic antidepressant can also be used in additional usages. Like for the treatment of childhood enuresis, we have this is the bedwetting. We normally use imipramine. In treatment for obsessive compulsive, we use the clopramine, right? This TCS can also be used as adjunctive analgesics. Okay. So remember, onset of action is very slow. It could have a lag period of about 3 to 4 weeks. So treatment should be at least 4 to 6 weeks before concluding that this individual drug is ineffective in treating depression. Okay, so if there is a partial response, treatment should be continued for several weeks before increasing the dosages. So treatment should continue for at least 4 months following remission. Withdrawal is normally tempered over several weeks. Tricyclic antidepressant can cause severe cardiotoxicity like the dysrhythmias in overdose. Suicide risk should also be assessed before prescribing, although it is not very sound as compared to the serotonin selective reuptake inhibitors. Okay, so selective serotonin reuptake inhibitors, examples include citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, and sertraline. These are the most commonly prescribed group of antidepressants currently, and the advantage with this drug is that they are less sedative and they have less antimuscarinic side effects compared to the tricyclic antidepressants. Okay. We also have acute toxicity. In case of the acute toxicity, you find it is less. We have less cardiotoxicity compared to even monoamine oxidase inhibitors or the tricyclic antidepressants. All right. So overdose risk is reduced. However, there is a concern about the use of selective serotonin reuptake inhibitors in children and in adolescents, in that there are reports that there is normally increase in suicidal thoughts when starting the dose or when increasing the dose for that case. Okay. Mechanism of action is that these selective serotonin reuptake inhibitors, they do inhibit reuptake of serotonin by the nerve terminals by competing with the amine transporters. So you can see, guys, inhibiting the absorption, so they block that, and then now the reuptake of this of serotonin is reduced. So in the end, we have more serotonin available for action. All right. These drugs can be used in treatment for depression, anxiety, and even post-traumatic stress disorder. In terms of pharmacokinetics, selective serotonin reuptake inhibitors are well absorbed and most have a plasma half-life of about 15 to 24 hours. Fluoxetine in this group is the only one that has a longer acting, between 24 to 96 hours. There is a delay of 2 to 4 weeks before the therapeutic effect develops, and this is common with most antidepressants. If you look at paroxetine and fluoxetine, they are not used in combinations with the TCS because you find that the selective serotonin reuptake inhibitors may inhibit the TCS hepatic metabolism and thus are going to increase the TCA toxicity, especially the cardiotoxicity that we fear most with the TCS. All right. Also, the SSRIs will also increase the levels of carbamazepine, phenytoin, monoamine oxidase inhibitors, benzodiazepine, and lithium. So because of the potentially fatal interactions between monoamine oxidase inhibitors and SSRIs, you need to have at least 14 days. That is around 2 to 5 weeks elapse between their use, okay, between when you want to use a monoamine oxidase inhibitors and also the SSRI treatment. We have some side effects, and these side effects normally happens within 3 months. Patients could present with weight gain, And patient could also present with sexual dysfunction, whereas there is loss of libido, erectile dysfunction, and failure of orgasm. So drugs like sertraline and paroxetine are associated with this. So you just need to remember sertraline with sexual dysfunction. Remember, in this group of drugs, there is no sedation as compared to the TCS where we had sedation, especially when you're using amitriptyline, right? So there have been also reports of increased aggression and occasionally violence in patients treated with fluoxetine, especially when you are initiating this therapy. Also, SSRIs are also associated with insomnia. So what do you need to know about these ones? These drugs, they lack cardiovascular effects, okay? And this is a primary advantage of these SSRIs over the TCS and even monoamine oxidase inhibitors. Now, the use of SSR is not recommended for treating depression in children under 18, and that's what we had indicated because of efficacy is still doubtful, and also we have associated adverse effects, including excitement, insomnia, aggression in the first weeks of treatment may also occur. The possibility of increased suicidal ideation is also a concern in this group. Now, when you use selective serotonin reuptake inhibitors in combinations with monoamine, we are likely to lead to a syndrome, a condition we refer to as serotonin syndrome. And this is characterized by tremors, hyperthermia, cardiovascular collapse, from which deaths have occurred. Okay? Serotonin syndrome is simply a cluster of autonomic, motor, mental status changes that are resulting from excess serotonin available. So we normally abbreviate it with serotonin syndrome shivers, where the patient will be shivering, will be presenting with rigid muscles, restless and agitated, will have increased temperature. Vital signs will be vital signs instability, whereby the heart rate will have increased, the respiratory rate will increase, but the BP will be dropping for that case. Okay. Patient could also present with encephalopathy, and therefore they are going to present with altered level of consciousness. The patient will be sweating, okay? And remember, above all, we have the suicide risk that will be increased, okay? And the age group you have said between 18 to 24. So remember, the RN has to report if the patient is presenting with more energy without corresponding change in depression for that case. Okay? Okay, guys, that takes us to the third group of antidepressants, and these are selective noradrenaline reuptake inhibitors. Examples include maprotlin and reboxetine. Mechanism of action, they simply inhibit the reuptake of serotonin into the noradrenergic nerve terminus. Okay? The fourth group is the monoamine oxidase inhibitors. Okay? The MAOs. Examples include phenelzine, and we have the triclopramine, the isocarbazide, and we have the phenelzine for that case. So generally, these drugs, they work by inhibiting of monoamine oxidase enzymes, okay? And when they do that, then we reduce the degradation of noradrenaline, dopamine, and even serotonin drugs for that case, all right? So within the nerve terminus, the monoamine oxidase normally regulates free intraneural concentration of noradrenaline or serotonin, hence the releasable stores of these transmitters. So monoamine oxidase inhibitors normally bind to these enzymes covalently, and this result in non-competitive and long-lasting inhibition. This will commonly cause a rapid and sustained increase in the serotonin, noradrenaline, and dopamine content of the brain. So serotonin being affected most and dopamine least. Monoamine oxidase inhibitors drugs are not particularly specific to their actions, and therefore they can inhibit a variety of other enzymes as well as MOA, and that explains the other side effects that normally come up with this drug. So unwanted side effects could include things like hypertension, excessive central stimulation may cause tremors, excitement, insomnia, and even an overdose could result into convulsion for that case. Okay. Also, we have increased appetite leading to weight gain for weight gain in patients, which can be so extreme to require drug to be discontinued. Anticholinergic effects like dry mouth, blurred vision, urinary retentions are common with these mouse. The most common and dangerous side effects associated with this drug is hypertensive crisis, and this follows ingestion of amine containing foods, beverages, or drugs. So interactions with other drugs and foods, interaction with the drugs and foods is more serious problem when you are using these monoamine oxidase inhibitors drugs. We have the cheese reaction, which is a direct consequence of MOA inhibition and occurs when amines, majorly the tyramine, are produced during fermentation are ingested. So tyramine is normally metabolized by the monoamine oxidase in the gut, okay, and liver. And little data tyramine will reach the systemic circulation. So when we have monoamine inhibition, this will allow tyramine to be absorbed and also enhance its sympathomimetic effect. So the result is acute hypertension that is giving rise to severe throbbing headache and occasionally even into intracranial hemorrhage. So although many foods contain some tyramine, the main danger is from ripe cheese and from concentrated yeast products such as the marmites for that case. We have the moclobemide. Moclobemide is this one is a specific monoamine oxidase A inhibitor, and this one does not cause cheese reaction. Okay, and this is good for your information. You need to note it down. Generally, cheese, meat, yeast extracts, red wine should be avoided in patients who are using monoamine oxidase inhibitors. So administration of indirectly acting sympathomimetic amines like ephedrine and amphetamine also can cause severe hypertension in patients who are receiving these monoamine oxidase inhibitors. Hypertensive episodes have been reported in patients being given the TCS and monoamine oxidase inhibitors simultaneously. So these monoamine oxidase inhibitors can interact with pethidine to cause also severe hyperexia with restless coma and hypotension. So we have now these other antidepressants which are atypical. They can neither be classified as the other four classes that we have mentioned. We have bupropion, and this works by blocking dopamine reuptake. So the main advantage of this drug is that it has high potential of the disadvantage, it has the high potential of inducing seizures, okay, and that becomes its downfall, okay. But this drug is contraindicated in patients who are hypersensitive to it, and those with either a seizure disorder because it can lower the seizure thresholds, and even those with history of anorexia nervosa. Remember, if you look at bupropion, it is also a CY450 inhibitor, okay, along with these other drugs. Bupropion can be used as monotherapy or as an adjunct, and we have many types of depression, bipolar disorders where it can be used. So another important role for bupropion, it can also be used in smoking cessation, right? And this drug can also counteract the sexual dysfunction, and it's safe to use in cardiac patients, right? Side effects could be insomnia, appetite reduction, weight loss. The good thing is we don't have sexual dysfunction here, nor weight gain. So common, we only have the mouth, dry mouth, nervousness, insomnia, and appetite reduction. The other atypical antidepressants is the flazine, right? It inhibits the reuptake of noradrenaline, serotonin, and dopamine, and it results in rapid improvement in depressive symptoms. It's more effective in more severe cases of depression. Concurrent use with this SSRIs normally carries the risk of serotonin syndrome, which we have already looked at. Okay. The third and atypical drug antidepressants is the trazodone. It's a weak serotonin uptake inhibitor, all right? And for that case, it has some unwanted effects like sedation, hypotension, and cardiac arrhythmias. Generally, this drug is metabolized by the P450, so you need to watch out for the interaction. It is normally used in treatment of anxiety, depression, but used primarily for insomnia as high doses are needed for antidepressant effects. Side effects, we say talked of toxicity, where we have sedation, nausea, priapism, postural hypotension. It's called trazodone, and this is majorly because of its male side effects, okay, like the priapism, all right? Okay, guys. Next, we have the nefazodone, and this is as a chemical and pharmacological similarity to trazodone. It works by blocking serotonin and noradrenaline reuptake. It's a drug of choice in depressed patients with comorbid anxiety symptoms. It's more effective in more severe forms of depression and in relapse prevention. Unwanted effects include sedation. However, the sedative effect is moderate and it may be helpful in depressed patients with comorbid insomnia. Next drug is mirtazapine, and this one blocks alpha-adrenergic, the serotonin receptors. Okay, it promotes presynaptic release of both noradrenaline and serotonin, but does not inhibit reuptake of either of these neurotransmitters. Something striking about this drug is that it has a faster onset in action than these other antidepressants. Okay, remember most of these antidepressants, we've said it will take around 2 to 4 weeks for us at least to see a change. All right, okay. Unwanted effects of this mirtazapine include dry mouth, sedation, and weight gain for that case. Okay, next drug we have lithium, and the mechanism remains unclear, but it may involve alteration of ion concentration, flashes across excitable neural membranes, as well as second messenger, particularly the inositol phosphate. Pharmacodynamics is this drug is normally given by mouth as the carbonate salt and is excreted by the kidney. So about half of this oral drug is excreted within 12 hours. The remainder presumably represents lithium taken up by the cell and is excreted over the next 1 to 2 weeks. These drugs has a very slow phase. That means with regular dosage, lithium can accumulate slowly over 2 weeks or more before a steady state is reached. Sodium depletion normally reduces the rate of excretion by increasing the reabsorption of lithium in the proximal tubule, thus increases the likelihood of toxicity. So a patient with hyponatremia is at risk of that toxicity because of such. Okay. Also, diuretics that do work in the that act distally in the proximal tubule also have this effect, and renal disease also predisposes someone to lithium toxicity. The main unwanted effects that occur during treatment include nausea and vomiting and diarrhea, tremor, renal effects like polyuria, especially with resulting with the thirst, so resulting from inhibition of the action of the antidiuretic hormone. At the same time, there is also some sodium retention associated with increased aldosterone secretion. So with prolonged treatment, serious renal tubular damage may occur, making it essential to monitor renal function regularly in lithium-treated patients. We also have thyroid enlargement, sometimes associated with hypothyroidism, along with the patient presenting with edema, weight gain, drowsiness, ataxia, nystagmus. even acute lithium toxicity resulting in neurological effects, progressing from confusion and motor impairment to even convulsion and death if the plasma concentration of the drug reaches between 3 to 5 milliosmoles per liter. Lithium is used in prophylaxis and treatment of mania and also in prophylaxis of bipolar or unipolar disorder. That is the manic depressions or recurrent depression. Dosage is between 0.4 to 2 grams daily, which is normally divided dosages depending on renal function and plasma level achieved for that case. Something you need to know about lithium is that this is a narrow therapeutic, has a narrow therapeutic window. So the likelihood of developing side effects from this drug is very high and also has a long duration of action based on the half-life that we had said about that case. Okay. We can also have acute toxic effects, which include cerebellar effects, nephrogenic, diabetes insipidus, and renal failure. Okay, so those must be adjusted according to the plasma concentration. Elimination is normally via the kidney and is reduced by proximal tubular reabsorption. Diuretic also increase the activity of reabsorptive mechanism and hence can precipitate lithium toxicity. We have talked about thyroid disorders and mild cognitive impairment, which can occur with chronic use. Therapeutic effect takes several days, just like other depressants. In terms of drug interactions, we've already indicated the diuretics. They will increase plasma lithium, and other drugs also alter sodium balance, like steroids and angiotensin converting inhibitors. All these drugs might increase the lithium plasma levels. Lithium also potentiates the neurotoxicity of other antipsychotics like haloperidol and flufenthexol. So you have to always check clearly for potential interaction before you administer lithium with another drug. Okay, so we have TCA drugs, guys, and these are the dosages, daily dosages for most of these. We also have the second and third generation, okay, like those ones, right? Okay, guys, remember the TCA drugs, they are associated mostly with the sedation, all right, sedation of drugs and even cardiotoxicity. Okay, so SSRIs comes in handy in that they have less cardiotoxicity, they have less antimuscarinic effects, but the only problem with SSRIs is there is increased risk of suicide in the young population, right? Then you have the selective noradrenergic reuptake inhibitors, and then the monoamine oxidase inhibitors, and this one you have said they are more associated with hypertensive crisis. Lastly, we have looked at the atypical antidepressants, and in this case, we had a number of drugs like mirtazapine, which we said it has a faster onset as compared to other antidepressants, and bupropion, which can be used also in smoking cessation. Okay, guys, that maps the end of our session on antidepressants. Remember to check the description to get the free quiz so as to be able to assess at least your understanding and cement your knowledge in this assignment. Thank you so much.